about approach to seizure disorder. So coming into the seizure disorder, we see a lot of cases into the emergency department coming with the generalized seizures and all. How do you approach the cases of seizures, and what is the history you need to take? And there are different causes of seizures. That can be epilepsy, that can be a seizure disorder secondary to some metabolic derangement or some trauma or hypoglycemia or some infection. Whatever is the cause, how do you treat that cause? So, a 40-year-old male known case of chronic alcoholic had last drink 8 hours ago, now developed a new onset generalized tonic-clonic seizure. So, this patient is not a known case of seizure disorder. Now, he was a chronic alcoholic used from long time. Now, he stopped drink, like last drink was 8 hours ago. Now, he developed a new onset GTCS. So, what is the seizure? So, whether you call it an epilepsy or whether you call it a seizure. So, anything that is causing a recurrent seizure, that is a epilepsy syndrome. Per se, any trigger is there, that is mostly some metabolic derangement or some alcohol is there, then mostly we call it as a seizure disorder. So, here is a chronic alcoholic, last drank was 8 hours ago. So when you call, whether you call it alcohol intoxication related or alcohol withdrawal related seizure. So, how do you differentiate it? So, first thing, generally alcohol intoxication causes, what does alcohol intake, what is the effect of alcohol per se? Alcohol acts on the GABA receptor, so it decreases the seizure threshold per se. So suddenly when alcohol is removed from the GABA receptor, so that is causing, because sudden removal of GABA agonist activity is removed, that is causing the hyper excitability in brain, that is causing the seizure. So that is why alcohol withdrawal seizures are common. Per se, alcohol intoxication is rarely causes seizure per se. So unless some metabolic derangements are present, so alcohol withdrawal seizures are more common. And also alcohol withdrawal has a specific pattern. Generally, all the alcohol withdrawal symptoms start after 6 hours. So initially after 6 hours, it starts with tachycardia and hypertension. So initially patient will tell palpitations and all, hypertension will be there. So anywhere between 6 to 48 hours, first he will develop alcohol withdrawal seizures. So most of them have seizures in 6 to 24 hours only. 90% of cases will have seizures between 6 to 24 hours, but can occur anywhere between 6 to 48 hours. So that is time he will generally have GTCS, GTCS seizures, and most of the time they can be managed with the benzodiazepines, that is lorazepam or diazepam or midazolam, whatever is available. So after 48 hours, what will happen is he will become delirium, that is a called delirium tremens. So delirium tremens, what is that? After 48 to 72 hours, what will happen is the patient will become sleepless, and also he feel that he keeps on hallucinating that he's back to work and starts to do whatever activity he used to do before, like farming, or whether he works at desk job, or he will start doing that activity. He can't sleep, he become very restless and all, and he's having all palpitations and sweating and all. So this is the delirium tremens phase, where he has that hallucinations and excessive tachycardia will be there, sweating will be there. He feels like he's back to work and starts doing all the activities. Like if he is farming, is like if he's doing work, desk job or something, he starts doing the desk job, though he was not back at work. He feels that he's back to his environment. So during that phase, most of them can be benzodiazepines, or rather you can give haloperidol also if severe psychosis is there. So this is the various phases of alcohol withdrawal. So initially tachycardia and hypertension will be there. Then alcohol withdrawal seizures can occur anywhere between 6 to 48 hours. So mostly occur between 6 to 12 hours only. Then the after 40 hours, the delirium tremens phase will come. So this is the pattern how alcohol withdrawal occur. So in most of these seizure disorder, initially you can give diazepam, then you can hike up to the, if required, generalized like a valproate or phenytoin or levipil can be given, but most of them can be managed with diazepam and all. That is benzodiazepines and all. And also sometimes phenobarbital can also be given for both delirium tremens and alcohol withdrawal. Phenobarbital can also be given. But the thing is, most of them doesn't require the long-term anti-seizure prophylaxis, because there is the alcohol withdrawal. Only when if you are able to treat that alcohol withdrawal, like if you are able to abstain the alcohol intake and put them, if there is put them abstinent and all, that is enough, because he won't go to alcohol withdrawal unless he drinks again and all. So the main role in this patient is to maintain the alcohol abstinence in them. They don't require generally long-term anti-epileptic prophylaxis unless some structural damage happened in the brain. So this is alcohol withdrawal. So coming to the same topic, what will happen in alcohol intoxication? Generally, what will happen in alcohol intoxication? There is excessive GABA activity and all. So generally, what will happen is most of them will have gastritis, vomiting and all. So that is the main stage. The Mallar's tears, they will be there, and also they will have mostly confusion first. So first thing is Korsakoff psychosis, Wernicke's encephalopathy. They are more common. Most of them are confusion. Like in Wernicke's encephalopathy, they will have confusion, ophthalmoplegia, and nystagmus will be there. Some ataxia also will be there. So that is Wernicke's encephalopathy, where you need to give thiamine along with glucose insufficient. The prolonged phase of Wernicke's encephalopathy is Korsakoff psychosis, where the patient will be, there will be some amount of memory problems also. He fills the gap. When you ask him about what did you eat in the morning, he doesn't remember what he ate in the morning. He fills up with something like he ate idli, though he ate idli, but he'll tell I ate dosa. He'll start creating story around it, though he doesn't remember it. So that is called Korsakoff psychosis. There is also one more thing in the late phase. If the prolonged chronic alcoholism is there, there is something called demyelination of corpus callosum, all that can lead to prolonged coma and mental confusion. Generally seen in the chronic alcoholics, if they are not improving from the altered sensorium and all, you can think of any demyelination is there in the corpus callosum. What is the disease of that demyelination of corpus callosum? You tell me of that. But mostly in acute phases, you find Wernicke's encephalopathy, Korsakoff psychosis, gastritis, vomiting, and also some electrolyte disturbances will be there. Hypoglycemia will be there. So you need to correct all. I mean, especially in the case of acute alcohol intoxication or chronic alcohol intoxication, any patient alcoholic, you need to correct first blood glucose, thiamine levels, magnesium. So these three are very important in this phase, and monitor for liver enzymes. So these four parameters are very important in alcohol intoxication. These are the things. These are the three important things that needs to be. In the most of the management of alcohol withdrawal is IV fluids and all, along with that glucose and will be thiamine will be given, but also benzodiazepines play a main role, and later on alcohol abstinence is the main part. They need to be put in some de-addiction program and all. That is the difference between. So this is the case of mostly alcohol withdrawal after 8 hours, mostly 6 to 24 hours is the time. You can start them on benzodiazepine, and also chlordiazepoxide can be given, so that GABA activity will be that long acting benzodiazepine like chlordiazepoxide can be given, so that GABA activity will be made. Slowly it still needs to be tapered off. So that is how this is an alcohol withdrawal seizure mostly. You need to put them on chlordiazepoxide. Just not giving the short acting, chlordiazepoxide also needs to be put on them, so it will maintain that the GABA activity. Sudden withdrawal won't be there. So a 20-year-old female with history of febrile seizures in childhood, now present with the symptoms of abdominal pain and unpleasant smell, followed by unable to speak with movement of left hand and right upper limb dystonia. So 20-year-old female. So always when a patient comes to with you with a seizure, you need to ask what is the semiology of seizure. So what is semiology of seizure is, how did it start? So we will discuss again what is the semiology. Otherwise we will come back to case scenarios. Once you remember this, we will come back. In the semiology, you need to ask whether it is, first you need to ask is whether the seizure is not pseudo seizure. So what is seizure and what is pseudo seizure? Seizure will have some tonic or atonic or clonic movements will be there. In the case of pseudo seizure, most of them will be conscious and all. They will be able to recollect completely. Most of the seizure patients are unconscious and they can't recollect, and pupils will be dilated and all. So they have sudden thrusting movements, and also they like some waxing movements, like not proper tonic clonic movements like waxing and waning, and they have thrusting pelvic movements will be there. And also when you call them in between, they'll wake up and like you can make it out like sudden thrusting. And also one more thing you can tell them is I will put a tuning fork on your head. If the seizure is there, it will provoke the seizures. Most of them will act seizure whenever you put the tuning fork on the head, so that you can make it out. Generally tuning fork on the head doesn't stimulate seizures. So that is one more test you can do. First, always rule out whether it is seizure or pseudo seizure. You need to rule out. Then you should always check whether there is any metabolic derangement. So you can label it as seizure. Then seizure or epilepsy. Epilepsy is any recurrent seizure, any recurrent disorder that is causing a recurrent seizure is called epilepsy. So if it's the first time, always look for any seizure. Always first time it is always labeled as seizure. If the recurrent seizures are there, then you can call it as epilepsy or something. So first seizure, you should always look any infection, any fever is there, any neck stiffness is there, any meningitis symptoms are there, any altered sensorium encephalitis symptoms are there, you need to check. Then you always check for any electrolyte disturbance, any hyponatremia or any hypercalcemia or hypocalcemia. Even you should need to check for calcium magnesium levels also should be like hypomagnesemia can also cause seizures. So all of these electrolyte disturbances needs to be checked. Then you check for high blood sugars also. Any hypoglycemia is there, you need to check. So sometimes hyperglycemia also, because cerebral edema can cause. And also any CVA, any focal deficits are there, or any headache, long-term headache, any tumor is there, anything, any long previous infection like sometimes tuberculosis and neurocysticercosis can cause calcified granulomas. They can cause seizures at some present point. So first, always infection, GRBS, electrolyte disturbances, any headache, long-standing headache, any previous history of infection, all needs to ask before going into the history. If these are anything was there, so if there is hypoglycemia, you correct the hypoglycemia. The patient doesn't need long-term medication of anti-seizure prophylaxis. The same way, if the patient has electrolyte disturbances, the patient doesn't need long-term prophylaxis of anti-seizure. You correct the electrolyte abnormality, make sure that doesn't come back again. The patient has infection, only during that time the patient requires anti-seizure prophylaxis Like HSV sometimes herpes simplex may sometimes require long-term anti-epileptic management, but most of the infections doesn't require long-term anti-epileptic management per se. During that acute phase they require. And also in the tuberculoma and NCC related granulomas, they might require long-term prophylaxis because they have already structural damage of calcified granulomas are there. So in that cases you might need to put them on long-term anti-epileptic drugs and all. And let's say the patient has a mass or something, he might require long-term anti-epileptic drugs and something. So always check sugars, electrolytes, infection, any previous history of infection, and all of these things. Then after you made it out, then always ask what is the semiology of seizure. What is the semiology of seizure is how did it start. There are various terms in the semiology, so you need to ask for any aura, any automatism. So any he has any motor movements, what are the language things and all. So what is aura? The aura is a sensation, like you have sensory aura where you feel tingling, numbness and all. Motor aura, the patient start moving limbs or something like that will be there. Auditory aura, like he starts hearing something. Visual aura, he starts seeing something. Gustatory aura, he was able to taste something. Olfactory aura, he was able to smell something, unpleasant smell. So these are all auras. So these you can tell them. Generally most of them, like let's say you can localize it also. Visual aura are localized to the occipital lobe. Auditory aura are mostly localized to temporal and parietal lobe. So like that you can localize what kind of aura is there, so that you can localize at a particular point. And also automatism. What is automatism? Any repetitive construction which are not purpose is there. Let's say hands are moving here and there, and also legs are moving, and there is no purpose, like restless leg. So there is no purpose, but he keeps up moving rhythmatically and all. These are automatisms. So these are automatisms can also simple and complex. Simple is just a movement, complex is like bicycling and all. So sometimes complex automatism can cause, like it mimics like an activity. They like bicycling, and also they can do random activities which mimic the normal actions and all. So they also will be in automatism. And also language, whether he was able to speak or not, whether he was able to like guttering is like, there is no per se any words, but say guttering is there. And also if there's he was able to communicate properly, or there is complete speech arrest is there. So that is called language. And also these are all the phenomena will help you to localize where the seizure onset is. So that is one of the most important in seizure, the semiology. How did it start? Is there any aura? How did it start? How it went on? Like let's say that this patient, I'll give you an example from this. The patient has previous history of febrile seizure. This presented with symptoms of abdominal pain and unpleasant smell. So these both are aura symptoms. So this pain abdomen is an autonomic symptom. So autonomic aura can be urination or like defecation, like any passage of stool or something. Abdominal pain can be there. Any tachycardia can be there. So that is like abdominal pain is an aura. So generally auras are most commonly seen in the case of mesial temporal lobe epilepsy. Medial temporal lobe epilepsy is the where commonly we see auras. So most commonly we see auras in like these auras, especially the autonomic auras and this olfactory auras are most commonly seen in the case of that function is that the olfactory lobe function is that's why these auras are most commonly seen in their temporal lobe. So generally this started with an abdominal pain, which is an autonomic aura, then followed by unpleasant smell, that is also olfactory. So then he was unable to speak. So generally what is that is mean? So there is an aura, he was unable to speak, he arrested, he was not able to speak. So what does it mean? If the patient generally how will our speech come? Most of the speech comes from the dominant temporal lobe, that is left temporal lobe. So he was unable to speak, that means that there is dominant temporal lobe is involved, that is left side temporal lobe is involved. So generally right temporal lobe seizures they won't cause language problem, they will be able to speak. But left temporal dominant temporal lobe have a complete speech arrest and all. So that one more thing will be there. So this is unable to speak is one more suggestive of dominant temporal lobe is there, because temporal lobe is the language area, so he was not able to speak. So then movement of left hand is there. So left hand is there. So this went to left lobe. Then right upper lobe dystonia is there. So ipsilateral this one more feature of the temporal lobe is ipsilateral automatism, and contralateral dystonia is one more feature of mesial temporal lobe epilepsy. So here the history will help you to localize what kind of onset of the which lobe is involved. Let's say like the parietal lobe will have the sensory symptoms, because parietal lobe has sensory function. Occipital, most of visual manifestations will be there. Frontal lobe mainly functions in motor functions, and for that the social behavior, like for thinking and all the sympathy, empathy. And the medial lobe is a medial part of frontal lobe is also having emotions also, behavioral part is also involved. So the mostly motor or behavioral emotions or force thinking, something will be there in the case of frontal. In the temporal, mostly you'll have language, olfactory pathway, memory pathway, they will have more. So this is mostly mesial temporal lobe, because febrile seizures is one of the risk factors of the mesial temporal lobe sclerosis. So that is one more guiding feature. Now the symptoms start as autonomic and mostly olfactory. So olfactory is a temporal lobe. So that is why this is in olfactory, mostly located temporal. Generally auras are most common in the medial temporal lobe rather than lateral temporal lobe. So that is one more suggestion of medial temporal lobe. Then followed by unable to speak, that suggests of left dominant temporal lobe, and then movement of left hand and right upper lobe disturbed. So this might be a case of mesial temporal epilepsy, medial temporal lobe epilepsy. Most of them don't respond to drugs. They might require surgery. So most of the time we do MRI in this patient. If you don't find any structure, any cause like any GRBS is normal, electrolytes are normal, and also all the infection is ruled out, no granuloma, CT is all normal, then you need to go MRI and EEG in all the patients whom you don't find definitive cause. So MRI epileptic protocol is where you look for temporal lobe sclerosis mainly. So MRI epileptic protocol and EEG needs to be done on all the patients where you don't find specific trigger for the seizures. So this might be a case of medial temporal epilepsy which doesn't respond to drugs much. So 90% of the cases they won't respond to drugs. Most of them require surgery. So this is one case which doesn't respond to drugs much. So a 30-year-old female presented with complaints of seizure in the night associated with lip smacking and mastication and repetitive movements of hands and legs. So here again this is also semiology. This started with the nighttime seizures. So one of the classical features of frontal lobe epilepsy is they start in the nighttime and more frequently they come. So nighttime seizures is one of the characteristic features of the frontal lobe epilepsy, and also it is has hypermotor. Generally temporal lobe epilepsy is hypermotor, they won't have much motor movements per se, whereas frontal lobe epilepsy is hypermotor, they will have more movements per se. So this one more thing, complaint of seizure night with lip smacking. Lip smacking and mastication is involved in the case of opercular area, that is in the frontal lobe, medial part of frontal lobe, opercular area will be involved. So that can cause lip smacking, mastication. These are suggested. These are also something like automatisms only. So these are also involved, like opercular area can be involved. So nighttime seizure is one thing, friendly, like hypermotor, followed by repetitive movements of hands and legs. So this is one more thing classical of front, like hypermotority, nighttime seizures, more frequency will be there, and they won't have any post-ictal confusion, but they'll able to recall all the activities what happened. They won't have post-ictal amnesia also. So this is the classical of frontal lobe seizures where they'll have nighttime hypermotor activity, more frequent activity. They have little amnesia, most post-ictal confusion won't be much. They will be able to recall, and also they have some, like there can be lip smacking and mastication can be there. Sometimes they'll have complex bicycling like movements. Sometimes they have repetitive movements of hands and legs are there, but sometimes complex automatism like motor movements might be there sometimes they might be like if the frontal pole is where the our most of our attention and also social pathway is there. Sometimes they'll like I was forced to think something or something like that. The frontal lobe epilepsy can present that way also. Which part of frontal lobe is involved plays a major role. So you need to understand the frontal lobe functions. The frontal lobe has many things. The lateral part of frontal lobe, which is the dorsolateral, the lateral part is mostly involved in the executive function. That is motor activity. Per se, it causes movement of limbs and all. There is supplementary motor area which organizes the after which like the alignment, like this step has to occur before, after that this step, like they'll make a procedure that will be enacted by the motor area. So this is mostly the lateral motor area. The frontal pole will mostly occur in the sympathy, apathy and social pathway, where we'll have how like our thinking or attention will come from there, our thinking, our new ideas come from there. So if the frontal pole is a where seizures, they have forced thinking, and they have like some this social empathy and sympathy will be disturbed. Whereas in the case of medial part of the frontal lobe, mainly involved in the behavioral pathway, like and also motivation is involved in the case of medial part of the frontal lobe. So they won't have any interest. This medial part of the frontal lobe will you might have heard of ebulia, akinetic mutation. So we'll discuss about in the stroke again. But the medial part of frontal lobe is more involved in the case of motivation and all. So sometimes they will all be in the orbitofrontal pole, whereas the behavioral pathway is involved. So these can be various parts of the frontal lobe. Based on the which part of frontal lobe is involved, you'll have that such automatisms and such aura will be there. Here opercular areas, that's why lip smacking and hypermotor is there. So this might be a case of frontal lobe epilepsy. Case for a 28-year-old female has a history of seizure disorder and had semiology as she started hearing voices, and followed by anxiousness, followed by tonic-clonic movements. Like I mentioned, so this is the semiology started with hearing voices. Where will we start hearing? The auditory. So auditory pathway is mostly started temporoparietal area. So temporal area is where the primary auditory cortex is there, then goes into the secondary auditory cortex is in the temporoparietal junction is there. So this might be a case of temporal area, mostly lateral temporal. Lateral temporal is where in the auditory cortex is there. Followed medial part mostly olfaction, lateral pathway is mostly auditory. So then followed by anxiousness and tonic-clonic movements. This is the lateral temporal lobe epilepsy, where more generalization, more like the generally medial temporal lobe epilepsy doesn't spread much, whereas lateral temporal epilepsy generally spreads to the other parts, so that's why it calls tonic-clonic movements. So these hearing voices will give you guide. This that is a semiology is important. Where the symptoms start is the first thing important. So hearing voice is the first thing, then followed by anxiousness and all. So this might be a case of lateral temporal lobe epilepsy. So since it started auditory. A 50-year-old male history of visual hallucination. So visual hallucination generally followed by eye blinking on, followed by deviation of eyes. So this might be visual hallucination generally started occipital lobe, followed by rapid eye blinking. Will tell you that is all in the occipital lobe. That is followed by deviation of this mostly occipital. So deviation of eyes can be seen in the case of frontal lobe epilepsy also because of the frontal eye field involvement. So that can also be seen, but this might be this deviation of eyes can be seen in occipital lobe. But that is a predominant. The deviation of eyes is a late symptom in occipital lobe. When the frontal lobe it involves early. So, but primary it started visual hallucination. That will give you a guide. Visual hallucination, rapid eye blinking. These are all occipital lobe function. So this will tell you it's normally occipital lobe epilepsy. A 30-year-old male has a fell from bike and had history of new onset seizure and had regained consciousness in 15 minutes. So any trauma patient, he fell from bike, so he developed seizures. So will you put them on long-term anti-epileptic? Initially you will give anti-epileptic drug. So will you put them on anti-epileptic drug or not? So generally it depends upon the how much time loss of consciousness is there. Generally, if anything more than 24 hours loss of consciousness is there, he might require long-term anti-epileptic drugs and management. But if anything less than 24 hours, he might not require long-term anti-epileptic. He might require only 2 weeks to 3 weeks of anti-epileptic drugs. He will recover mostly. So that is why any patient who is lost consciousness for more than 24 hours, he definitely requires long-term AEDs. But if less than 24 hours, he might not require AEDs for long time. He might require anti-epileptic drugs only for a short duration of time. That is one more thing I want to highlight. So always, this is the approach, always ask for the trigger, like any sleep deprivation is there, any hyperventilation is there, and also ask for any flashing light exposure is there. They can tell you good, like there are triggers for certain epileptic syndromes like absence seizures, there is certain trigger, and generalized GTCS certain trigger is there. So I will trigger, but always ask for the history. You need to ask the history first. Any sleep deprivation is there last night, any hyperventilation is there, any strobing of lights is there, you need to ask for history. Any risk factors, what are the risk factors, any previous infection is there. It's like hypertension is a risk factor, usage of alcohol withdrawal is a risk factor, and also depression, any psychiatric disorder is a risk factor. So you need to ask for any history of a headache, long-term headache, any tumor is there, any previous history of TB or NCC is there. These are all risk factor for seizure disorder. Seizure or pseudo seizure, as I mentioned, seizure and seizure based on the thrusting, pelvic thrusting movement, waxing and movements, and they are conscious, they can recall well, pupils you can check, and also vibration tuning fork you can do and tell them no. Check GRBS, electrolytes, any bleed or CVA should be checked, infection, autoimmunity. This all needs to be done. And get imaging and routine electrolytes and all needs to be checked. If you are not able to find a cause, always get MRI epileptic protocol and EEG to look for any epileptic syndromes. So terms, epilepsy is what is recurrent seizure. Seizure is first time. Focal was generalized. Focal is something which is localized to a certain point. Like let's say if it is localized to occipital, we will only have visual symptoms. If it is localized to only upper limb, you will only upper limb. That is focal. Only upper limb, only whatever part of the brain is that is focal. Sometimes it comes secondary generalization. That is called Jacksonian march. Jacksonian march generally, this also will help you differentiate between the pseudo seizure and seizure. So Jacksonian march how will occur? Let's say the focal seizure started in the right upper limb. So that means left sided frontal motor, left sided motor cortex and so it slowly spread to the left sided lower limb motor cortex also. So the same side lower limb will be involved, then goes to the opposite side right lower limb, then it goes to the right upper limb. So this is a pattern. This is called Jacksonian march. So left upper limb, left lower limb, right right upper limb. So this is a pattern because that is how cortex spreads. So left upper limb near area is left lower limb, then it goes to the right lower limb, then goes to the right upper limb. This is called Jacksonian march. But what happens in pseudo seizure? So they'll start moving left upper limb, then they start moving right upper limb also. That is not Jacksonian march. That is pseudo seizure. So that Jacksonian march pattern also will be there in the pseudo seizure. That is one more thing you can differentiate. And also one more thing, focal seizures can be with loss of consciousness, without loss of consciousness, and also generalized is something which occurs generalized seizures. So again, tonic, there are different kinds of terminologies like tonic seizures, clonic seizures, tonic-clonic seizures, atonic seizures, myoclonic seizure, ecstatic seizure. There are many kinds of seizures. So you need to ask them also. And also sometimes after seizures there will be paralysis also. That is called Todd's paralysis. So if generally it recovers like after, because of the rigorous motor activity, the limb may stay paralyzed for some time, but it will slowly recover within 12 hours or something. If it continues for more than 1 or 2 days, it might call epilepsis partialis continua. So that is one more thing you need to learn. That is a NEET PG bit actually. So NEET SS bit actually. So this is focal with impaired consciousness with preserved consciousness and generalization, which we discussed about Jackson and March. So general tonic and clonic. Tonic is anything the tensing, like tonic is increased tone person. That can be any single muscle group or anything. Tonic is that. Clonic is repetitive contraction of the muscle, initially followed by fast movement, then slow movement. First movement is fast, then slow movement. So clonic movement is fast movement, slow movement. Fast movement, slow movement. That is clonic movement. Tonic is mixed of tonic and clonic. Atonic is sudden loss of tone. So sudden loss of tone in muscle group or something, like suddenly hand falls aside. That is called atonic. Myoclonic is a involuntary chronicle that lasts less than 100 milliseconds or all. So that myoclonic is a very small jerk, that is like you felt my sleep jerks are myoclonic jerks. They start for less than 100 milliseconds, they last. That is myoclonic jerk. There sudden jerky movements will be there. They last very small time. That is myoclonic jerk. Aesthetic is the sudden loss of postural balance because of the loss of tone of all the muscles. The sudden loss of tone, he falls down. So aesthetic is something seen in LGS syndrome and all. That is aesthetic. So these are the various types: tonic, clonic, atonic. Tonic is increased tone. Clonic is fast movement and slow movement. Fast movement and slow movement. Atonic is sudden loss of tone. Myoclonic is sudden jerky movements. Aesthetic is sudden loss of posture. So these are the various terminologies you need to use. And also ictal. Ictal is during the seizure phase. Post-ictal, is there any confusion or not? Generally frontal lobe won't have much confusion. Temporal lobe will have confusion for long time. They'll have amnesia also. Medial temporal lobe mainly will have amnesia. So that is one more thing. Interictal is in between ictal. We do EEG if you find any findings and all. So that will hide you tell about epileptic symptoms. That is why ictal, how is the ictal phase? You need to ask the semiology. How did it start? How did it end? Post-ictal, if there is a if there is any confusion or amnesia is there. Generally confusion won't be there in the case of an amnesia won't be there in frontal lobe. Generally confusion and amnesia is more predominant in the medial temporal lobe epilepsy rather than lateral temporal lobe epilepsy. They are more common in MTLU. So interictal, you will check for any EEG spikes and there or not. So always we just got for semiology, you need to ask about aura. So that can be sensory aura. Sensory aura mostly commonly seen in parietal lobe syndrome. Motor aura mostly seen in the case of frontal lobe syndromes. Visual aura, occipital lobe. So autonomic aura is mostly seen in the case of medial temporal lobe epilepsy mostly, and olfactory aura is seen in medial temporal lobe. Gustatory aura can be that it gives you taste. So these are all different kinds of aura that can be seen. Automatism, that can be simple and complex. Simple is something a simple movement. Complex, it looks like a normal activity like bicycling and all. So automatism can be motor automatism mostly. Motor automatism what we see. So complex motor automatism is majorly seen in frontal lobe epilepsy. So that is automatism. That is rhythmatic movements, but there are no purpose for them. So they keep moving limbs, but there is no purpose for it. So any posturing is there. Like we mentioned in the case of medial temporal epilepsy in the first case, there is ipsilateral movement is there. There is contralateral dystonia. So that is classically seen in the case of medial temporal lobe epilepsy. And figure of 4 posture. Figure of 4 posturing is something seen in the case of frontal lobe epilepsy. So the wherever hand is raised, opposite to that frontal lobe epilepsy is there. So figure of 4 like raised hand opposite side is the lobe inward. So figure of 4 appearance is classically seen in the case of figure of 4 or pensing posture is commonly seen in the case of frontal lobe epilepsy. So that is these all will help you to guide where the localization is there. Language. If speech is completely absent, that means the dominant lobe of temporal lobe is in there. If speech is present, that means dominant lobe is not involved. If he is not able to speak properly, he is not uttering words, but guttering, that grunting is there, guttering is there. That is more commonly because of the motor activity of the vocal cords. That is frontal lobe epilepsy. So if speech is absent, dominant temporal lobe. If speech is present, that is non-dominant. If he is guttering, not speaking any words, guttering because of the motor activity of frontal lobe, that can be frontal lobe epilepsy. So these all will help you to get localize the various the deviation. There is one more thing called eye deviation. There is called versive eye deviation. Eye deviation can be seen in the case of frontal lobe disorders and also occipital lobe. So that will also tell you what kind of generally eyes are deviated to the opposite side of the lobe. That because frontal lobe, right frontal lobe cause the opposite deviation. So towards which side it is deviated, opposite to that is the where the frontal lobe epilepsy is there. So eye deviation will have. So these are all symptoms will help you to get where the localization of seizures are there. So these are the visual aura. Visual aura can be seen in the case of mostly occipital, auditory, olfactory, gustatory aura, somatosensory aura, autonomic aura, abdominal aura, psychic aura. Sometimes psychic aura can also be that can be due to in the case of behavioral like amygdala, hippocampus. If there are psychic aura can also be there. So clonic movements we discussed, myoclonic we discussed, any epileptic spasm, and like these are all various things that can help you in diagnosis of diagnosing, localizing the symptoms, and this versive seizures, like versive seizure lateralized to the contralateral hemisphere. This is one more thing that can be versive seizures in the case of frontal lobe, that is eye deviation is there, no, lateralized to contralateral hemisphere. So that will help you the guiding the changes. So tonic is something is there, fencing posture, like fencing posture is there in the case of frontal lobe epilepsy. So contralateral the raised arm. So this versive deviation is there, contralateral to the option, fake a sign of 4. That is also seen. These are all seen in the case of frontal lobe epilepsy only. They are seen in the case of opposite to the raised arm or opposite to the eye, which side eye is deviated is the where the seizure is there. So frontal lobe sudden onset and offset, generally short duration will be there. Nocturnal frequency more common as we discussed in the third case, and also early motor sense. Mostly the motor, because motor area near to that, more early motor sense will be there. So bimanual and bipedal, both hands and movement legs will be involved. So little or no, there won't be any confusion or amnesia per se. So frequently they'll have some vocalization like guttering or something will be there. So multiple in nights. So no wandering or like that, they won't wandering, but recall will be present. They will be able to record. This is a classical of frontal lobe, short duration, hypermotor, nocturnal, and also early motor involvement will be there. No postictal confusion. They will be able to recall better. So this is the classical of frontal lobe seizures. So this is the difference. This is the temporal lobe. So there is a medial temporal lobe epilepsy and lateral temporal lobe epilepsy. So medial temporal lobe, always aura will be there, behavioral arrest will be there, automatism will be there, amnesia will be there. So aura, epigastric aura, as we discussed, they'll have motionless state. This is the behavioral arrest we are saying. So always 4 A's. Aura, that can be mostly autonomic aura or olfactory aura. Arrest is behavioral. Suddenly they'll start doing some, their motionless stare will be there, that behavioral arrest. So the speech arrest will be there in the dominant lobe. Then automatism, there some hand automatism, something like that. So ipsilateral limb automatism and contralateral dystonia is something classical in the medial temporal, and they won't be generalized, so they won't spread to the other areas per se. This is the classical of MTLA. Aura, behavioral arrest, so they were motionless stare. So automatism, ipsilateral automatism, contralateral dystonia, and some posturing will be the ipsilateral, less commonly generalized to the local generalization to the other sides. And history of febrile seizures is one more thing you can take. They won't respond to drugs also much. 90% won't respond to drugs. They will need surgery. So lateral temporal epilepsy mostly will have auditory or like mostly something they hear something or something like that, and they will have anxiousness, and then followed by late generalization is more common in the case of lateral temporal epilepsy. So this is one more thing, lateral temporal epilepsy. They have more auditory area when compared to the autonomic area and olfactory area, and they have more generalization. So more frequent generalization will be there. Automatisms will be more less common, and dystonias won't be there, but they will have more generalization because lateral temporal lobe is more near to the other cortical areas. So that is why secondary generalization is common. In this, automatisms and dystonias are not there. Amnesia is also less common in this case. So these are the temporal nodulation. Generally aura will be present, and the frontal are vague and specific. Generally frontal are brief, and frequency is also high, whereas temporal frequency is very less, but but they occur for long time. And also frontal is abrupt onset and more frequent, and generally they will have a generally slow in onset, and they will have some automatism. Here also automatism, but more of motor, and they have grunting and screaming. Frontal have grunting and screaming. They might speak based on the hemisphere that is involved. Generalization is uncommon in temporal, whereas generalization is common in frontal. Postictal confusion is more common in the case of temporal lobe, but it is not seen in the case of frontal lobe. So this is the main thing. Temporal lobe, mainly they will have aura, they won't have generalization, they have more postictal confusion, and they have more less frequently and last for more time. And also they have aura, automatism, behavioral arrest, and postictal confusion are more common. Whereas frontal, more frequent, nocturnal, short duration, they won't have postictal confusion, or they will be able to recall, and mostly occur in sleep, and more motor activity, hypermotor, whereas temporal is hypomotor. So this is how you tell the temporal and frontal. So parietal lobe, most of them will have seizure, sensory or like numbness or tingling, then they generally spread to the other areas. Mostly they have secondary generalization more common. So most of them won't observe sensory symptoms, tingling and numbness, most of them won't recall much, and burning pain they won't recall. They generally tell with the GTCS only. So this is the parietal lobe epilepsy. So most of them have no parietal, but rather manifestations spread to the other areas will be the most common presentation. So occipital lobe, some visual hallucinations will be there. Sometimes simple or multiple. Simple is seeing some red color or something. Complex hallucination is something where you start seeing faces and all. Complex is something which you can like routinely you see. Like routinely is normal world how you see that is complex hallucination. Whereas simply seeing some red dot or something is hallucination. Complex is seeing a face is complex hallucination. So hallucination, visual illusion, blindness can be sensory symptom. This can be occipital lobe epilepsy. Motor like blinking or nystagmoid movements. Any movements can be occipital lobe epilepsy. These are occipital lobe epilepsy symptoms. So this is the ending. Always ask for seizure or pseudo seizure. Always ask GRBS, electrolyte disturbances, infection, trauma, CVA, any autoimmune etiology. Then look out whether it's tonic or atonic, clonic or ataxic. Always ask for semiology if there is any aura. So olfactory, medial temporal lobe; auditory, lateral temporal lobe; visual, occipital; motor or any behavioral changes or social changes, frontal; sensory, parietal; automatisms are more common in medial temporal lobe epilepsy. So that can be asked. Any like motor automatisms are more common, like bipedal or bimetal. Hypermotor automatisms are more common in frontal lobe epilepsy. Is there or not? Then you can ask for language. If he is able to speak, non-dominant. Speak, not able to. If he is not able to speak, dominant hemisphere. If he is grunting or something, frontal lobe epilepsy. Always ask for eye movement. Eye deviation is there. Versio eye deviation, contralateral to the side. Any posturing is there, like figure of 4 fencing posture is seen in frontal lobe epilepsy. So opposite to the raised hand is the where the epilepsy is there. So then ask for any then you ask for any you also ask for like any how much frequency, any like in the case of frontal lobe, any nocturnal is there, hypermotor, short duration, high frequency, no postictal confusion, they are frontal. Temporal is less frequency, more duration, more aura, more automatisms, and also more postictal confusion, and they don't respond to drugs. Occipital, visual, parietal, sensory. This is how you approach a case. Any patient you are not finding a triggered cause, like any no electrolyte disturbances and all, always get an MR epileptic protocol and EEG. If you find a specific trigger and all, then you need not do MR epileptic protocol and EEG per se, because they have specific trigger. And most of the patient who has specific trigger, like alcohol withdrawal or something like there is electrolyte disturbance, you need not put them on a long-term anti-epileptic drug and all. Only there is a structural damage or epilepsy syndrome is diagnosed, only you need to put them on anti-epileptic drug. Thank you. On long term. Thank you.